So the next topic for the day will be current update in MISC in children. So this will be presented by Dr. Suma Balan, who is currently working as a professor in the Department of Rheumatology in Amrita University. Ma'am's research interests include rheumatology, and ma'am is serving as an editorial member and reviewer of several international reputed journals and is the member of many international affiliations. She has successfully completed her administrative responsibilities and has authored many research articles or books related to rheumatology. We cordially welcome you, ma'am.
Thank you. It's my pleasure to be part of this meeting, and I wish I could have been there in person. I'm a Pondicherry girl, and Pondicherry is always in my heart. So what MISC was something that actually created some excitement in pediatrics, because when COVID-19 started, it was very, very boring for pediatricians. And many of them were actually not having much to do. But then in late April 2020, a new disease was started affecting children and presenting in a very sick state. And it was noticed that this was happening 3 to 4 weeks after a community acquired the peak of their COVID-19 wave. Roughly a 2 in 100,000 reported incidents, but now it's considered to be more than that. And it's due to immune-mediated hyperinflammation. And roughly, this is what is happening. I mean, we know that the first stage of SARS-CoV-2 infection is the asymptomatic, mildly symptomatic stage, and then the nasopharyngeal colonization, and then the pulmonary infection. So beyond that, you have the hyperinflammation phase, where you have a delayed immune system that's getting activated, and it's producing a lot of changes. A cascade is being released, which causes a hyperimmune response. And it's this hyperimmune response that affects different parts of the body, different organs, and causes the features of MISC. There's been a flurry of research, and earlier this year, researchers from France actually were able to show the superantigenic response that happens, which triggers off this hyperinflammatory cascade. And they showed that this particular polyclonal expansion of T cell receptor V beta, CD4 and CD8 clone cells is the hallmark of multisystem inflammatory syndrome. These cells were found in the children who developed the condition. And this is again just showing how the wave of MISC follows the wave of COVID-19. And when do we suspect MISC? So there are different case definitions. If you look at the CDC, it's below 21 years. If you look at WHO, it's below 19 years. So any child between 0 and 18 years who develops a high-grade fever, who has the clinical features that we will see shortly, and who has significant inflammation, both on clinical examination and on the labs, and who has a temporal link with COVID-19, you consider the possibility of MISC. You do need, it's a diagnosis of exclusion, you do need to exclude other diagnoses too. But this is the kind of clinical context in which you will think about MISC. And what is we have various case definitions. I think most of you in this audience would hopefully have seen cases and would be familiar with the WHO case definition. It just details the kind of clinical features that you expect to see, the kind of lab inflammation that you expect to see, and the COVID link that we know about. So this is roughly a child with MISC will be showing a number of these kind of clinical features, in addition, which quite commonly we do see with Kawasaki disease. In addition, they have gastrointestinal symptoms and signs. They have pericarditis, myocarditis as well. And these are many of our patients and various signs that they had. You can see the kind of cracked lips. You can see the rashes. You can see the eye changes. You can see even these kind of acral changes that are there, the gluteal region, tip of the toes, and the various different kind of rashes, etc., that you can see in these patients. So when we look at the clinical phenotypes of MISC, it's been described as patients who have MISC without a typical Kawasaki or with, not with acute COVID-19. So this more or less the toxic shock kind of presentation. Then you have MISC with overlapping with acute COVID-19. So this patient develops MISC often on the recovery phase of COVID-19. So they could actually be RT-PCR positive as well. And these patients did tend to have a higher mortality rate in general for many reasons. And then you have MISC overlapping with KD, where it looked a little bit like KD, but and this was usually the younger group of children who developed MISC. Now, what is interesting is that in any of these, or across all the three categories, the risk of coronary aneurysms was equal when it came to patients with MISC. How do we know if it is MISC or it's Kawasaki disease? So there are many things, the clinical features, the fever, the rash, the mucositis, the conjunctivitis, hand and feet, edema, cervical lymphadenopathy. These can be common to both conditions. However, MISC tends to occur in older children, tends to have more of gastrointestinal symptoms, which is quite unusual in Kawasaki patients, and a very significant rate of myocarditis and cardiac involvement presenting with shock, which is only about 5% in Kawasaki disease patients. When you look at the labs, they have leukopenia, where you have leukocytosis in Kawasaki, lymphopenia, where you actually have significant neutrophilia in Kawasaki, and thrombocytopenia, where you have actually thrombocytosis in Kawasaki. And treatment-wise also, there is a much more increased incidence of requiring intensive care and intensive care related procedures, including ECMO and the use of other drugs than IVIG in these patients. Differential diagnosis should not be forgotten. I think everybody would have seen a case they thought was MISC, but turned out to be toxic shock or scrub typhus or dengue fever or something else. So it's something, when you see it, you do need to think, could this also be something else? So how do you evaluate a patient? We looked at the history and the examination. You do have to take a strong COVID link history. Do remember that the majority of patients would have had COVID, but nobody would have known they had it. Their children are often very asymptomatic, have very mild COVID-19. They would never have got tested. It's usually somebody in the family who had COVID, or you do an antibody and find that the antibody is positive to give you the COVID link. And of course, the presence of shock and organ dysfunction. Put it very simply, in the COVID era, any child who presents with fever can be MISC. However, every child who presents with fever may not be MISC. So how do we investigate these patients? So these are all slides I made for the COVID pediatric content creation in preparation for the third wave. The third wave we're still awaiting. Anyway, so if you have a patient who presents with very typical features as fever, there's all the clinical features and a COVID link history, you're fairly sure you could be dealing with MISC. Is this child having shock and life-threatening manifestations? Then this is a kind of child whom you should be doing both the tier 1 and tier 2 test workup while you work up for common infections. But if you think this child fulfills the criteria, go ahead and start treating them, especially if they have cardiac shock or multi-organ dysfunction. You can start the treatment for MISC while workup for common infections continues. If your child does not present with the typical features of MISC and you cannot really fit them in, but you can't be completely sure, the idea would be to evaluate for alternate diagnosis while you monitor for evolving MISC. And while you monitor these patients, you could actually do tier 1 evaluation. If that's positive, you go for tier 2 evaluation. And similarly, if you're monitoring them and they develop more features suggestive of MISC, then you do the complete evaluation and you treat them based on how they turn out to be. At every point, there is the caveat, do rule out common infections too, while you're thinking about MISC. What are the tier 1 and tier 2 investigations? So the tier 1 investigations can be done virtually everywhere. It's just simple counts, a complete metabolic profile, a CRP and an ESR, along with COVID-19 testing, as well as a blood culture. So if you have a positive tier 1, that means you have evidence of inflammation, you have evidence of probably a low lymphocyte count, a low platelet count, and low sodium, neutrophilia, and hypoalbuminemia. And then you go for the tier 2 test. Tier 2 tests are a little bit more advanced. So cardiac ECG, echo, NT-proBNP, troponin, inflammatory markers, further inflammatory markers like procal, ferritin, and D-dimer, fibrinogen, etc. I think the important thing to realize is that none of these individual tests is diagnostic of MISC. And another very important thing is that the D-dimer is more of an acute inflammatory activating agent in this scenario. It's just like a CRP. It is not an indication of needing to start anticoagulation. We need to realize that these tests are only towards pinpointing the degree of inflammation that the patient has. And of course, the COVID link that needs to be investigated. How would you manage these patients? It's particularly important to focus on the sick ones, so the ones who present with shock or multi-organ dysfunction. I think these patients should be considered for early referral to a pediatric intensive care unit because they need the definitive treatment as well as good supportive treatment. And if they are RT-PCR positive, they should be managed in a COVID care facility. So if they present with shock, they need the whole treatment. That's IVIG, 2 grams per kilo over 12 to 16 hours. And in our setup, if we have a sick patient with shock, we do try to optimize giving the IVIG over this period, even if it requires a child be ventilated to achieve it. We get better results this way. IVIG is a wonder drug in these sick children. They start responding so nicely, and it really makes a difference to give it in as much optimum time as you can, rather than giving it very slowly, or rather than give it split up over several days. Along with that, the advice is to start IV methylprednisolone. When I have a patient in shock and I'm fairly convinced this is MISC, I do tend to go for the higher dose straight away, 10 to 30 milligram per kilo per day with a maximum of 1 gram per kilo. However, to be entirely careful, if you're not completely sure, then you start with 2 milligram per kilo per day and escalate if your patient is not improving and you know you've ruled out other causes of this condition. If your patient presents without shock but has a Kawasaki kind of phenotype, then again you give them IVIG plus 2 milligram per kilo per day of IV methylprednisolone. You can escalate if required. For your patient who doesn't have the typical, what we call the febrile inflammatory syndrome, you have to be very, very, very careful with these patients. And I think this is very, very important because what is happening is that today we are having a lot of patients who come with fever, had a COVID story a month or two ago, or perhaps they are antibody positive, and you don't know what is wrong with them. The fever is not settling that easily. And so what is happening is they're all being just labeled as febrile inflammatory syndrome post-COVID and given steroids, and they seem to respond. Now, we've had 3 children in the last 2 months who were given steroids like this who actually had a hematological malignancy. So it's very, very important that while there are some patients with just a febrile inflammatory syndrome who are not very sick, who do not have the shock, who do not have this, the typical KD type of features, I suggest there are some of them who present with MISC, but we have to be very, very careful about giving steroids to this group unless we have proved that other diagnoses are not possible. Do remember 1/3 of patients can be RT-PCR positive and use biologicals. if all this is not adequate, then we consider biologicals, which can be tocilizumab, infliximab, or anakinra, depending on what the clinical presentation is. But I would suggest taking tertiary consultation towards using biologics. Seem to progress. Yeah. The other aspects of management are very important. So appropriate supportive care of cardiac dysfunction, coronary involvement, shock, etc. While they do say you can give IVIG slower, in children with cardiac failure, it's probably more optimal that we try to get the IVIG in. And as I said before, if you need to ventilate to do it, please consider doing that. And overall, we taper the steroids over 2 to 3 weeks and stop it. And we use aspirin for all children, probably for 3 to 6 months, till we have made sure that whatever dilatations and aneurysms are there have resolved or are not going to present. And the anticoagulation is indicated only, not based on D-dimer, but indicated only if there is giant aneurysm or a very low ejection fraction or presence of any thrombosis. And they do need a careful echo follow-up. Now we have, in the first wave, a number of publications have come out from India of various case series. Ours was also published a couple of months ago. And what is interesting is that looking through all these, because they are more or less 1 or maybe 2 institutions, the numbers are not very high. Whereas if we had managed to put all our numbers together, we would beat any country hands down, I'm sure. Now we can see, however, that significant amount of shock in these patients. We can see that more or less the ages were 6 to 7 years. And we can see the kind of about 30% again of RT-PCR positivity in most of them. And there were some deaths that have been responded. In most cases were treated with IVIG plus or minus steroids or steroids alone. And this was our experience, which we published a couple of months ago. This is from the first wave. And our mean age was around 6.2 years. We needed about 88% of our patients required intensive care and 20% required mechanical ventilation, 51% required inotropic support, and about 5% died in this group. And we found also that patients who presented with hyperferritinemia seem to have a higher risk of requiring ventilation. And about 16% of our patients had some residual echocardiographic changes at 3 months follow-up. And most of those, I'm glad to say now, have resolved. So the important thing is that early recognition is very important and appropriate treatment. And we can see, again, one of the important things is that from studies from the West, we found slight differences in our experience in that our children were younger. Most of our children, 80%, were completely previously healthy children, and obesity or high BMI was seen only in 10% of our patients. And this is how it fared. When we looked at a systematic review that was present, this is our study experience, but it does correlate with many of the other studies published from India too, that comorbidities were significantly lower in Indian patients. We had younger age of onset in general, and we had more frequent coronary abnormalities. There are places from India, more of steroids alone have been used in India, but the outcomes are not really known. And another very surprising thing was that very surprisingly low incidence of MISC being reported from Far East countries, which normally have a very high incidence of Kawasaki disease. And we had some challenges too, 35 to 40%. In our hospital, we had even more sick patients requiring intubation ventilation, high inotrope requirement. One of our patients required ECMO, and we had other abdominal emergencies and 2 patients with complete heart block requiring emergency pacing. So what is the literature so far? This is a very, very important study that came out in JAMA in March this year, where they looked at a retrospective cohort study with the propensity score matched analysis. And what they found was that patients were much better off being treated with a combination of IVIG and methylprednisolone versus IVIG alone. And it was overall reducing the risk of treatment failure, the need for second-line therapy, the need for hemodynamic support, and left ventricular dysfunction, and reducing the duration of stay in pediatric intensive care unit. So this was kind of a landmark finding, which did change, I think, a lot of policies across the world. Then in June 2021, the NEJM had 2 studies published about the treatment and experiences of multisystem inflammatory syndrome in children. This is the American study across a large number of US units called the Overcoming COVID-19 cohort. And this group also found that initial treatment with IVIG plus glucocorticoids was associated with a low risk of new or persistent cardiovascular dysfunction than IVIG alone. However, this was published in the same edition of the NEJM, and this was the BATS consortium, which involved units across both sides of the Atlantic. And however, they found that the outcomes were no different whether you used IVIG alone, IVIG plus glucocorticoids, or glucocorticoids alone. And this really created a lot of confusion in the treatment of MISC. However, looking very closely at this data, what was realized was that this group of patients is really not similar to the group of patients in the previous study. And there were very much more milder patients incorporated in this group. And also, there was a lot of differences in the way they were looking at their outcomes. So I think even these authors do agree that in the sick children, it is much better to use both drugs together. What about outcomes? So we have one study which showed a 6-month follow-up, and it did say that overall mortality is around 2% across many studies. In Indian data, mortality is 0 to 5%, but still largely good. And 6-month follow-up did say that there were very few organ-specific sequelae at 6 months, which is good news. But they did find that there was some mental health support and persisting poor exercise tolerance issues in these patients. So to conclude, this is a new disease. We need to be aware and vigilant. We need to be able to recognize the various clinical phenotypes. We need to be aware of how to investigate and how to interpret these investigations. We need to go for early immunomodulation and supportive therapy. Be aware that there can be quite bad sequelae if you don't treat these patients right, and take help from others if we are finding it difficult to treat these patients. It can really take all these individuals who are involved in getting this boy home. This was a boy with MISC who required to go on ECMO on a Saturday evening, and he did so well. Within 3 days,